spine. And what about the safety of sublaminar wires? So we actually read this paper, 4,000 wires under the lamina. We studied 4,000 wires in all indications, mind you. This is not just scoliosis. And we read this paper at the SRS meeting in Monterey in 2006. And the question that we asked was, is sublaminar wiring a neurologically safe technique? That's it. And as it turned out, 4,275 consecutive sublaminar wires with a longish follow-up had no neurological complications. So the sum and substance here is that if you have the right technique, you don't blame the implant. Just do the right technique and just keep following that technique, and there's a low chance that the implant is going to let you down. And finally, affordability. I mean, that's the bottom line as far as our patients are concerned. There is just no comparison between what I will spend for the cases that I've done here versus what a traditional current concept scoliosis surgeon would spend for his implants. I mean, the entire net worth of the implants that goes in to a case that is typically shown up here is like $40 or something like that, which is, it's a pittance. I mean, a meal would cost you that much. And head-to-head comparison, a single screw from a multinational company in our country would cost you maybe that much, right? So there's just no comparison here. And typically, working in a public hospital for a good part of my time, I think you have to think of this as one of the as one of the important decision-making factors before you offer the patient or not offer the patient any surgery. And finally, where would I still say that you want to try not to use this system? I think for me, a pure lumbar curve is a bad indication to use this system. Clearly, I would do an anterior screw rod system for a pure lumbar curve, or even a posterior screw rod system. And all the curves that Viral spoke about, the selective thoracic fusions, which are where you can really spare the entire lumbar curve. There is a pre-existing curve in the lumbar spine, not a myth, and you want to spare it. Because we have not been able to study, or no one has studied the derotation and the correction potential of the sublaminar wire system, we cannot stand up and say that you correct the thoracic spine with our system and the lumbar curve will fall in line. So I think in these two indications, you surely don't want to try to pull a stunt, and I think you would stick to the basic current principles. So I think I'll wind up by saying that the method that I propose, spinal loop rectangle with sublaminar wires, is an excellent implant for a bulk of your cases. 80% of your cases in practice would be happily dealt with this implant. It's safe, it's effective, and its applicability is wide. And the technique is very easy to learn and easy to replicate. You don't need a lot of gadgets. You don't need a lot of armamentarium. And for a country like ours, all of you, each and every one of you, should learn to use this implant, even if you know a good deal about the other implants. Thanks.
For three-dimensional correction or derotation, we need the implant should pass anterior to the instantaneous axis of rotation. So the sublaminar wires doesn't have a purchase beyond the instantaneous axis of rotation. So does it only translate or does it derotate?
So it's a very pertinent question, and clearly sublaminar wire, which is way posterior to the axis of rotation, is going to be a poor way of derotating. But when you actually have seen the biomechanical studies, only an anterior screw, which goes by an anterior approach, can really derotate your the way you would want it to. Even pedicle screws fall short. The current, individual vertebral rotation technique, I've really not, studied the principles, but I assume that may be one way of derotating. But global derotation techniques have clearly proven to be a myth. I mean, it's really not derotating the bones or the spine per se. So if you compare that to this, I think there's a very little trade-off, and that trade-off is acceptable. I mean, I would definitely say this is a less rigid and less strong, less forceful way of correcting. But I think what you lose out versus what you gain potentially, that trade-off is what I was trying to sell here. So
Thank you for your excellent presentation and your excellent results. I just need to ask you, so many very nice correction in the coronal plane. You show us just one nice correction in the sagittal plane. I noticed that you didn't show us as many lateral views of the spine. we recently, the Cincinnati Spine team published an article showing that hybrid constructs, that means constructs which are composed by 80% from sublaminar wires, didn't have as good as sagittal plane correction as the screw construct had.
Yeah.
Any comments on that?
Yeah. No, I think again I would take that fully. You know that pedicle screw can give you a much better sagittal plane control. Having said that, we didn't. Though honestly, at that time we did not study the correction in the sagittal plane because this was a 2001 or 2002 years or 2003 publication. But when you compare hooks to wires, I think it's a different thing because most of the hybrid systems include hooks which tend to distract and spoil your sagittal plane. Here you're giving the rod a shape. It's a stainless steel rod which is quite snobbish. It does not change, and you pull the spine towards you. And we've just had 2 cases where we had a distal junctional kyphosis. So I think that I think that would say that the correction is not too bad. But I think your comment is very well taken, sir, that if you had screws, you could get that correction as an angle much better.
Thank you.
Yes.
So,
Sir.
thank you very much. That was a great talk. And again, I still use a lot of wires in my neuromuscular kids, but I think in the States, this is a technique that is starting to disappear, and people who are training now don't know how to use wires. So I still think it's a great adjunct, even if you're using screws, and I think it's important that people know how to use it.
Yeah, thanks, sir, because that comment is very valuable to us. Because most of our trainees, including all of us, go home with a message that if you can't do screws and apothoracic screws, then you are not doing a good job. And I have seen people of your seniority using sublaminar wires as a bailout when their screw was either causing a neuromonitoring problem or if there was a burst pedicle. So all I'm trying to say is that you cannot go ahead without knowing this technique. It's a first stop shop and then you move ahead. Thank you, sir.
Coming to the cost, do you think when you use Indian desi screws versus this, I don't think it's a major cost difference
It's a
until
huge
otherwise
cost
you
difference
screw
until
every level.
Yeah, so in rupees, we'll have to translate it for them, but in rupees, an entire construct for say a 15 level implant would cost 15,000 rupees. Okay, and one single Indian screw in the cheapest means place where you don't want to buy it. An average good Indian screw is 3,500 rupees, but a really cheap stainless steel, what we call lohar chawl screw, is still 2,000 rupees. So it's still the cost, is because you would end up using like a third. I know because I get faced with this every day, and they call up and say what implants, and I say if he's not affording Hutchill rectangle, if he's affording screws, and there's no question of foreign screws in say Wadia hospital for example. So it's like at least it cuts the cost down by 3 times, even if you compare it with an Indian implant.
So I just want to make a comment. As I grow up in the spine practice, the couple of things that I realized, and we're just talking about majority of the idiopathic curves, is at the end of the day, spine does not know whether it's straight or not. The X-rays will tell you whether it's straight or not. Function-wise, I don't think it matters if you have a curvature which is after the fusion is 20 degrees versus 40 degrees or 45 degrees. What matters is balance. So you can do whatever technique that you're used to and achieve balance, and that would work. The second comment I wanted to make is, when we started using pedicle screws in my training at our place, the hooks were a lot cheaper than to use the pedicle screws. But the companies realized that, and what they did is that they increased the price of the hooks and make it same as the pedicle screw.
So
or maybe costlier.
Yeah. So one step ahead is in Japan, they used to like Professor Abumi I visited, and what they've done is that they've replaced sublaminar wires by tape, silk tape, which is more expensive than a pedicle screw. So it's clearly industry driven. I mean, it's it's a bad word to say here in a sponsored meeting, but the fact of the matter is that.
Well, the other thing is that I think what I have realized is that what you need for a scoliosis correction is a good foundation and a good proximal construct, and somewhere in between you need to control the apex. So if you are wanting to make the X-rays look good, and you don't want to spend too much money on it, I would probably just do lumber or the lowest instrumented level, as you shown, a couple of levels of pedicle screws there, and maybe 1 or 2 levels of pedicle screws supplemented with wires at the proximal end, and you can instrument the entire spine using sublaminar wires.
So we tried that because we thought at least the apex we'll be able to control with screws, and since we had access to these screws, unfortunately the foundation, there's no doubt, if you had screws it's better, but at the apex once you put the screw, the philosophy of a screw does not match with the philosophy of this correction, and it seemed like an obstruction in the correction. Once that screw was there, you try to derotate and fix it, the wires don't align the spine the way they would. For that, possibly if you have 2 L rods, it may make a difference because the 2 rods are independent of each other. But in this construct, we have to just abandon that.
I think
plan.
you need to stay with screws at the top and the bottom. In the middle,
Maybe.
I don't think that doesn't really make any
Because
sense.
again, the lengthening that you get intraoperatively is almost 2 centimeters in most of the cases.
Correct.
So these screws tend to hold you back. But maybe we keep them open and then let it.
Yeah. So if you
lengthen
contour
and
the
then-
rod in kyphosis, most of that lengthening will go in kyphosis. So in
Possibly.
a hypokyphotic spine, pedicle screws do not do a job, or it actually makes it even worse, maintaining the kyphosis. So
Sure. Thanks. Sir.
You showed two cases, 2 patients which had a distal junction kyphosis. What went wrong? I mean, did you actually?
I think, today we would not, I'm sure we would not have that. I think we didn't look at the kyphosis preoperatively. This whole thing about the sagittal balance was really not there at that time. Today, whatever cases we do, in the last 5 years, I've not had a single case with a distal junctional kyphosis, unless it's a neuromuscular where we've stopped short. They tend to, regardless, they tend to slouch off, and you always feel you should have gone, into the pelvis if you've stopped short. But otherwise, I think it was a poor assessment preoperatively more than anything else. While the coronal decompensation was because of lack of the availability of an implant. We had an implant that was so long we needed to go there, but we didn't have one available. Like a 320 millimeter long rod, we didn't have one longer than that.
One more thing that Dr. Jain actually said, and you said like the two philosophies did not match. This question is related to the other thing that we just mentioned about the screws and the wires. Like, how was your technique? Did you first put the rod between the top and the bottom and then try to pull in the spine to the rod, or were you like you started off from one end and then started pulling?
Yeah, I mean traditionally we would just tighten the concave rods first, the concave wires first, and someone holds the implant down. But
between the two things.
yeah, just all the wires on the concave side. So you just get a concave correction first.
Yeah. First, I was actually mentioning about the pedicle. You said you had
When we
five.
use the pedicle.
Yes.
So well, again we try to align the spine to the rod as much as possible, because most of the time the spine is outside the construct because it's 80-90 degree curves. So you try to get there as much as possible, and then try to fix the screw. The screws are already put in when you put the wires. After that you place the rod, place the rectangle, and you try and get as much coronal plane correction as possible, and then try to harness the screws. Unfortunately, once the screws get harnessed, that's it. After that, the wires don't contribute to correction. Okay, thank you.
Presentation by Dr. Viral on management of rigid AAS curves.
So management of rigid curves, and I'm sure you all know a lot about how to manage. This is basically a review rather than any specific technique. So what I consider rigid is curves that do not bend below 55 degrees, or the curves greater than 75 degrees, although they may not be rigid, but I like to put them in the same category. Or the other criteria is that the curves do not bend less than 50%. So if the curves bend more than 50%, then you have to use your traditional methods. The challenges are, as you all are very well aware, multiple medical comorbidities. And we're talking about AIS patients. So they still have diminished pulmonary function, nutritional depletion, anesthesia is challenging, positioning, airway, excessive blood loss, IV excess is a problem. It's a long surgery, coagulations can be off. I mean, it's not a simple, straightforward surgery. Surgical challenges, the quality of the bone and instrumentation. The anatomy is really distorted, and you do not get good fixation points. Solid fusion is must in this case, but the problem is, again, the autograft, because of the size of the patient, is limited, and overall health of the patient is also compromised, so you have trouble getting fusion as well. So physical exam, you have to look for the neurological changes, you have to get flexibility films, traction, side bending. MRI is probably more often than not recommended in this particular group of patients, just to make sure that there is no underlying etiology for severity of the curve. CT scan may be helpful for you to understand the anatomy based on what instrumentation you are going to use. The goal of fusion or surgery is to prevent further progression by achieving fusion. But more importantly, as I mentioned, achieve coronal and sagittal balance, which is more important. And curve correction and also cosmesis to a certain extent is important. In order to make the curve correction or make the curve better, you have to make the spine flexible, and also you can use instrumentation to hold it in that way. The correction of thoracic cage distortion can be achieved by costoplasty and rib resection, but again, these patients have compromised pulmonary function, and you do not want to compromise that further. So treatment strategies are single staged, which includes posterior release, combined anterior and posterior release, and posterior spinal osteotomies only. And then you can do intraoperative craniofemoral traction and do instrumentation. 2 stages, which is more standard for these type of patients, is a first stage is a posterior release, combined anterior posterior release, or just anterior release. Do traction, either halofemoral, halogravity, or you can use temporal internal distraction. You keep the patient in the traction for about 2 weeks to somewhere between 2 weeks to 4 weeks, and then come to a second stage and do your final instrumentation. So what's the advantage, disadvantage? Again, this is not a whole lot of clear, not proven, but consider that shorter operative time, less anesthesia, less blood loss leads to quicker recovery, less morbidity if you're going to do a single stage. However, 2 stages are, are relatively safer. You do gradual stretching of the spine, less risk of neurological injury, less risk of implant failure. And if you look at the morbidity that way, overall it's less morbid than to do a single stage long procedure. So this is a recent, fairly recent article where they did a randomized prospective study. There was no significant difference in some form of safety, such as neurological deficit or implant failure, or efficacy, means final COP correction was not much different between the 2 stage and the single stage procedure. Obviously, the significant difference was in the length of stay and patient cost. And there are multiple studies who would reiterate the same fact. So you can go either way, but personal experience is what drives the spine surgeons, and so most of the people would probably prefer 2-stage approaches. So what is this 2-stage approach? We'll start with skeletal traction, craniofemoral traction. So we're talking about femoral pin and cranial traction, either with Gardner Wells or Halo. So at our place, Melvin did this review in 2004, retrospective review, 24 patients. COP correction was 70%. Average traction was 54% of body weight. There were only 2 traction-related complications that resolved when the weight was reduced temporarily, and then they started going back up as well. The technique, always perform releases. So it is recommended whenever you are using traction for these group of patient, adolescent idiopathic, it's almost always necessary to do the release. The patients were placed on a horizontal turning frame or a striker frame, which is again obsolete. The Halo application was performed as described by Mubarak, and threaded Steinman pins were placed in the distal femur 2 centimeters proximal to the physis. Traction rods are then tied to the Steinman pins and wooden traction bar. And I'm pretty sure everybody in this room is aware we have been doing this type of traction for fractures and other disorders in pediatric patients for years. This is the same thing. There is nothing new in that. Traction is applied intraoperatively while you are doing the procedure. So intraoperatively, you start putting the patient in the traction while you are doing the stage 1 of the procedure, and then patient also leaves the room with traction. Neuro exam weight are added during the daytime when the patient is awake and is able to respond to your questions regarding the neurological symptoms. Weight is immediately reduced if the abnormal neurological signs or symptoms appear. Total traction of up to half of the patient's body weight, and then the second stage surgery is performed with traction. Complications related to halo application, neurological deficits usually are reversible. Distal femoral pin complications, decreased mobility of those patients because they spend most of their time on the frame, on the turning frame. So pulmonary complication, DVT, psychological implications, but more importantly, you need to have a bed or a frame where you can access the spine to check the wound, and also are able to prevent pressure source by frequent turning of the patient while not reducing or losing the traction effect. So this is what a striker frame looks like. The patient is supine. And it's basically a board. It looks horrible, and it is horrible. And if you ask a patient who has gone through it, you will know that they absolutely hate it. And I'm pretty sure everyone here would hate it as well. So this is the turning handle, and the patient is prone here. So when they are turning the patient, you sandwich them over the frame, and then you remove the top portion after you turn them. So per shift you are turned at least twice. So a shift of 8 hours you are turned twice. But anyway, this is since gone. It's a historical thing at our hospital. We do not use this that often at all, or rather not at all. But I do have to say that the results are really good, and this is what the X-ray looks like on a striker frame. As soon as you see the X-ray, you know it's a striker frame. Halo gravity traction is currently the one which we are using. Skeletal traction in upright position, weight should be enough to lift the buttocks until they are slightly off the chair. So, right in this area. This technique is basically completely suspends the patient's trunk in space, and the traction weight is provided by the body weight itself. There are multiple studies. Rinella was, a group from St. Louis, actually published a pretty decent study in 2005. Had 46% COP correction, no permanent neurological deficit, and they concluded that halo gravity traction is a safe and well-tolerated method of applying the traction. 6 to 8 halo pins are placed to minimize the risk of loosening. 6 to 8 inch-pound of torque is applied. Halo is placed resting slightly below the equator of the skull, just above the eyebrows, and just at the level of cephalad portion of the earlobes. Avoid the danger zones as described by Mubarak. We can talk about this for many minutes, but basically that a classical article, we have to follow that. You usually start with 3 to 5 pounds of traction, increase at a rate of 2 to 3 pounds per day as tolerated. The goal is to reach 1/3 to 1/2 of the body weight. Apply about 12 hours of traction minimum per day. At night time, you can reduce the traction weight to 50 or 75% of your day weight to avoid proximal migration in the bed at the night time. Look at the position of the bed. It has to be inclined so that the body is still providing the counter traction. And the traction is applied while in a bed. You can apply the traction while the patient in the wheelchair or in a standing apparatus, as we saw earlier. Neurological checks are performed every 8 hours, at least once every 8-hour shift, while in the initial phase you have to do it every 4 hours. Ambulatory patients use a treadmill or a walking frame to reduce the potential for diffuse osteoporosis and generalized deconditioning, and that is the biggest difference from a striker frame where the patients are stationary. Daily respiratory treatment and therapy to maximize pulmonary health. You do not have to take radiographs very often. This is a slow method of achieving correction. So the correction takes place over a 3.5 to 4 weeks time minimum, as opposed to in a craniofemoral traction where you usually the second stage is scheduled within about 10 to 14 days. So the duration of the treatment depends on how rigid the curve is. 4 weeks to 8 weeks is usual. So common complications, halo-related complications, neurological deficits usually are cranial nerve, sometimes brachial plexopathy, and frank neurological weakness is actually rare. So you have to look for, every day you have to check for their cranial nerves and check for their upper extremities. It is very common to have neck discomfort and soreness in the trapezial muscle, and you can just reduce the weight temporarily and then the patient gets better and you can put more weight. Psychological intolerance is really uncommon, and that is, I think, the biggest advantage of using a slow halo gravity traction over a halo femoral traction in that god-awful striker frame. So temporary internal distraction, it's a two-stage procedure, but it does not involve any traction externally. Stage 1 is soft tissue release and osteotomies, and you place 1 or 2 temporary rods, and then stage 2 is usually a week later. Remove the temporary rod, placement of final spinal implants, and fusion. Remember, if you are going to do this type of method, the anchor point will become loose during the phase, and so you have to carefully select your anchor points so that the final anchor points that you're going to use should not be included with the temporary internal distraction. So this is popularized by Skaggs, and this was published fairly recently and showed a very good outcome. No neurological deficits or infections are resulted. So cephalad anchors are ribs or the spine. You can use sublaminar hook versus the screw. Rib anchors are usually preferred. And if you're going to use ribs, you use 2 ribs rather than 1 rib. Caudal anchor points can be either lumbar pedicle or in the pelvis, especially if you're correcting pelvic obliquity or fusion to the pelvis, which is obviously you would not do in a walking patients with adults and idiopathic scoliosis most of the time. So the anchors that you use for temporary rod should be 1 or 2 level above and below of the most inclined vertebra, but should not be at the end of your construct. Rod-to-rod connectors and temporary rods you can use to connect, and then gradual distraction you can apply throughout the case, and then you can replace the temporary rod by a lower profile rod at the end of stage 1, and then you bring the patient back for stage 2 where you remove all the rods and you can do additional correction. So this is from their article. As you can see, they used pedicle screws at their anchor points at the proximal end and the distal end. This is the rod-to-rod connector. This is sort of a sloppy mechanism, and you can do temporary distraction while you are doing these procedures over a period of time during the stage 1. Same concept with using the rib as the anchor points and the pelvis as the other anchor point. You can use hooks, sublaminar hooks, and use the pelvic screws. Make sure that you do not use the same pelvic screw for your final fixation. So this is how it looks. A very severe scoliosis gets better with temporary internal distraction, and then stage 2, it was converted to a full spinal fusion. However, it's a fancy technique, and it has been spoken a lot at the meetings. I can tell you can do the same thing without using any of those fancy stuff. You just need to go back to your old Harrington set, find this thing, which is the Harrington distractor, and with outriggers. So you put the Harrington outrigger hooks, which are a little bit higher. It's probably almost about 2 inches higher, and you can put them in sublaminar position in the thoracic spine and supralaminar in the lumbar spine. Thread this distractor into those hooks, and throughout the surgery you can gradually do the distraction through this. So I think you do not need to be fancy. You can use this, and most of the places will have this somewhere stored, as you just have to get it. So single stage approaches, combined anterior and posterior approach, where you do anterior release and then you can do posterior approaches as well. So you can do anterior release open or video assisted. The video assisted is my favorite. In very young patients, one can perform ambulation and should do only annulotomies and should not try to destruct the growth plates. But we are talking about AIS, so that's not a concern. You can use rib as an autograft, or I usually use a fibular allograft. I cut it in 5 to 7 millimeter thickness and then put it in between the vertebral bodies. While if you are comparing with an open thoracotomy, VATS has advantages, but it's technically very demanding and not a whole lot of people do it. So in this picture you can see this is the intersegmental vessels. If you are just doing releases, you do not have to remove these intersegmental vessels, but I routinely do it. The reason is because if you coagulate the intersegmental vessels, you can mobilize the anterior vessels, which is usually the vena cava, away from the anterior longitudinal ligament, and you can go with your electrocautery or whatever mechanism you're using to cut the anterior longitudinal ligament without having to be worried about excessive bleeding. So this is the disc. You can do discectomies, and again you are doing. I usually, the goal is to achieve releases and not the fusion. So I am not that very good at doing discectomies through thoracoscopic approaches, but it does serve the purpose of doing the releases very well. And you can put a bone graft in between, and hopefully, usually in young kids, they usually fuse. So we started using the VATS for scoliosis. Till 2004, we were doing lateral position, thoracoscopic releases, and then turn the patient back to prone position and do the posterior procedure. Since 2004, we are doing it simultaneously. We are doing the patient in prone position, 2 teams. One team, this is our thoracic surgeon who is providing us the access. The one team works anteriorly, does the releases, does the fusion, while the second team starts working posteriorly and does the does the releases. By the time you are done with the anterior procedure, it usually does not take long. You can go back and do your instrumentation. We are blessed that we have surgeons and good fellows who can do the procedures, and so we are able to do this simultaneously. Of course, you need a lot of support in order to do these complex procedures. So we did a retrospective case control study at CCHMC. We presented it in AOS meeting 2009. And basically OR time, as you can imagine, is almost 4 hours less. But more importantly, blood loss was considerably less. Chest tube drainage for some reason was considerably less as well. And overall less morbidity. And this is one of my favorite procedures to do. Again, you have to be selective. You cannot assume that 100 or 120 degree curve will get an anterior release, and you get the same good result with this type of an approach. So let's talk about the releases and osteotomies. And this is a slide from an article published by Dan Sucato. At the bottom of the pyramid is interspinous ligament release and ligamentum flavum release. Then wide facetectomies, or what you call as pontiosteotomies. You can do anterior releases, rib resections, and you can do vertebral body decancellation or PSO, and then at the apex of the pyramid is the VCR. The complexity and the likelihood of complication increases as you go from bottom to top. So wide facetectomy is the removal of inferior articular process of the cephalad level and release of the capsule, whereas pontiosteotomy removes the ligaments, resection of the entire facet, as well as the capsule. So, what is a pontiostiotomy? We're talking about this particular level. You do laminectomy and you do the ligamentous release, and then once it is gone, you can resect the superior articular facets as well. So there are several papers which show that you get a decent correction from just doing pontiostiotomy. This is a paper which was published this year. You can see the estimated blood loss is considerably high, even though they were doing just the pontiostiotomies, and this is a mixed bag of patients as well. So what is our approach? You've probably seen this X-ray before. 83-degree curve, very rigid. What I did was did the anterior release, put the bone graft in, while the second team was working posteriorly and simultaneously. This patient, however, the curvature was too great, so we added concave rebosteotomies. We talked about this in our discussion earlier, as you can see right here. And then we did a VATS anterior release fusion, and then the posterior in the same day, single stage procedure. A stiff curve. In this patient, we did not do anterior release, just did concave rebosteotomies. And I think we also did convex no, not on this patient, but you can also do convex rebosteotomies and make the spine completely detached from the thoracic cavity. The only problem is you have to remember that you are creating a flail chest. The patient needs to go in the ICU, needs to have 2 chest tubes, needs to be intubated a little bit longer, minimum I would say 48 hours. You need to make sure the patient is completely stable, pain-free, and needs a lot more monitoring. So it's a lot more morbidity as opposed to doing just the concave rebosteotomies. Another example, we sort of had to do this temporary rod, because once we did the release, we started putting the instrumentation, the patient lost potential. So we removed the screws from the convex side, that brought the potentials back down, and then we put this temporary rod, and then I think that is the only temporary rod fixation that we have done for severe curves. Another example, this is the case that Dr. Sturm mentioned earlier. This number is not correct because our X-ray system does not measure any curves more than 90 degrees, so it goes back to 48. It's actually 130-degree curve. It's fairly stiff. First stage, we did the posterior releases, pontiostiotomy, put pedicle screw instrumentation, put the patient in the traction. As you can see, over a period of time, about 3.5 weeks, the curve got a little bit better with the traction, and then this is the final instrumentation, stage 2. So this is what we do currently. We usually do 2-stage procedures with halo gravity traction and releases. In the curves which are not so severe but severe enough, I do VATS releases and fusion in the same stage. So pedicle subtraction osteotomy, it's a V-shaped resection through the posterior elements. Hinge is anterior or lateral if you are doing just purely for scoliosis reason. Resection is entirely through the bone. Sometimes you may have to resect the disc space above. The osteotomy is closed in a way that there is bone-to-bone contact. This is from an article published by Keith Bridwell. So on the right side, Smith-Peterson osteotomy. I think it probably, for scoliosis correction, you would do pontiostiotomy, not the Smith-Peterson osteotomy. But pedicle subtraction osteotomy, bone-to-bone contact, and then you see the amount of resection. This is primarily done for kyphosis, but you can do asymmetrical pedicle subtraction osteotomy to achieve for scoliosis as well. So an example in a kyphosis patient, of course, you have to put your instrumentations in. You're going to have to do a laminectomy in this area. You do pontiostiotomies in the levels above and sometimes in the below. And then you put a temporary rod. I still believe that although PSO is not as destabilizing as VCR, I think it's safer to use a temporary rod regardless. And then you do, this is the exposure of the lateral vertebral body while we have finished the laminectomy. And then this is the exposure on the other side. You can see the cancellation or decannulation of the pedicle there on that side, and again on this side, as you can see. And then this is a lateral approach. This is starting with the decancellation of the vertebral body. The spinal cord is here, and this is the final. You gradually change the rod and make it a little bit straighter every time if you're doing kyphosis correction, and same way in the scoliosis. So vertebral column resection is the most morbid and most involving and the most challenging of all of these. It's a 3-column circumferential vertebral osteotomy, creating a segmental defect with sufficient instability so that you always require provisional instrumentation. And this picture is from an article again by Keith Breedwell. It's describing the kyphosis, a sharply angular kyphosis. So one or more vertebral segments. Closure usually does not imply bone-to-bone contact throughout, and if you are doing a lot of resection anteriorly, you have to put an anterior support with cage, just like this. So ideal candidate for pedicle subtraction osteotomy where substantial sagittal imbalance, sharp angular kyphosis, and there is circumferential fusion where we cannot do a pontiostiotomy. If you are just starting your practice, it's better to learn the technique in the lumbar spine where you are not dealing with the spinal cord directly. So this is an article published this year by Lenke and Spinal Deformity Study Group. 147 patients treated by 7 pediatric spinal deformity surgeons in the United States. Average of 1.6 vertebrae were dissected, or resected rather. Follow-up of 17 months. Operative time is 500 plus minutes. Estimated blood loss is 1600 ml as an average, which almost equals to 65% of the total blood volume. So the correction was considerably better. You can see 67% final correction. But you need to look at this number. 86 of 147 patients had one complication. That is 59%. 68 of these patients had intraoperative and 43 had postoperative complications. The most common intraoperative complication in this group of patients was 24% neuromonitoring changes. Now that does not always mean that you end up with weakness when you wake up, but significant loss of spinal cord monitoring data where you can document now the deficit at the wake-up test. Postoperatively, only few of those patients had weakness, and none of these patients had paraplegia. But that's a scary fact. The next most common intraoperative complication was a blood loss of more than 2 liters. The most common early postoperative complication was respiratory related. Infection was relatively rare. There were no deaths or paraplegia. So when you are mentioning in your results that there were no deaths, you can imagine how complicated or how complex this procedure is. So they also looked at posterior versus the combined approach, anterior and posterior releases while they were doing the VCR, and there was no significant difference in the number of patients who had intraoperative complications, but the length of surgery was significantly more in double approach. So at the end, I would like to say that I think if you want to take it, play it safe, and especially in a limited setup, I think you need to do a 2-stage procedure where you do a release on the first stage and then do traction and then do the final fusion. Vertebral column resection may be necessary in very severe cases, but you have to be very careful about dealing with the complication. And even though in the best results, in the best places or in best hands, you still have a lot of complications.
Shall we move on to the next one? Thank you, Dr. Viral. We invite Professor Stam.
So we've been talking about clinical issues, we'll take a step back and talk about how we can use basic science to help us solve our clinical problems. So two specific areas that we've looked at are junctional kyphosis and growth preservation, because I'm not sure we have the right answer for either of them. So this was a paper that we presented at the Orthopedic Research Society. It actually won the Best Paper Award. Transverse process hooks at upper instrumented vertebra provide a more gradual transition to normal motion in long posterior spinal fusion constructs. So we all know, especially with kyphosis surgery, but even with idiopathic scoliosis surgery, that proximal junctional kyphosis is an issue. Whether it's really a significant clinical problem, I think is debatable, but it's certainly something we see frequently on x-rays. It's defined as kyphosis greater than 10 degrees at the proximal transition level. Reports are between 17 and 39% of developing it within 2 years. People have looked at it, whether it's associated more with one instrumentation system or the other. It's inconsistent association with hooks, wires, and pedicle screws. Kim showed in 2012 there really was no significant difference in health-related quality of life if proximal junctional kyphosis happens. Yagi showed that normalization of sagittal balance lowers the risk of proximal junctional kyphosis. The risk factors, preoperative hyperkyphosis, thoracoplasty, and hybrid instrumentation versus hooks only. The effective construct type still remains controversial. So we thought that maybe that transverse process hooks at the superior end of a construct may decrease the risk of proximal junctional kyphosis by providing a more gradual transition and mobility compared to all proximal pedicle screw constructs. We looked at 13 skeletally immature domestic pig spines, preserved the posterior ligaments. We did either all pedicle screw constructs or a pedicle screw construct with a transverse process hook at the superior aspect, dual long rods, cobalt chrome, T7 to T14 pedicle screws, and T6 upper instrumented vertebra with either pedicle screws or transverse process hooks. We applied 4 Newton-meter bending moments in both lateral bending and flexion extension, and we did the outcome measure intervertebration every level from T2 to T11, and then primary assessment at T6, T7, and this is what the construct looked like. So that's the control, and that's the all pedicle screw. We looked at flexion extension, and we looked at uninstrumented versus transverse process hooks versus all pedicle screws, and stiffness at the proximal junction. So what you see is that the transverse process hooks below the proximal level are the same, but at the proximal level, while not the same as control, much, much different than the all pedicle screw system in flexion extension. Not nearly as much as in lateral bending, but in lateral bending as well. Stiffness at the proximal junction, significantly less in the transverse process hook group than in the all pedicle screw group, while both are much more than the control, and the non-instrumented segment above really pretty much the same throughout. So what we found was the non-instrumented control spines, range of motion gradually increased from T11 to T2. Flexion extension and lateral bending were in similar patterns. In the instrumented spine, large stiffness changes across the transition. Transverse process hooks were 6 times the control. All pedicle screws were 9 times the control. Flexion extension, range of motion, transverse process hooks were much more than all pedicle screws, and stiffness in transverse process hooks much less than in all pedicle screws. No significant difference between the two in lateral bending. So the type of end instrumentation significantly affected the range of motion and stiffness of the spine near the proximal junction between the instrumented and non-instrumented segments. Abrupt discontinuity with both the all pedicle screw and transverse process hook group. This was really the first biomechanical study of adjacent motion segment properties at the cephalad end of a long posterior spinal fusion construct. Transverse process hooks at the upper instrumented segment of long fusion construct provide a more gradual transition to normal spine mobility than pedicle screws. Whether this is going to be effective clinically, we really haven't established, but theoretically, transverse process hooks at a cephalad end may decrease the probability of progressive proximal junctional kyphosis compared to all pedicle screws constructs because of the more gradual transition to normal motion as opposed to the stiffer pedicle screw constructs. So the other thing we've looked at is growth preservation, and can we improve growing rod constructs? We know about the law of diminishing returns. Sanker and Skaggs reported it. Effective repeated lengthenings decrease over time. It may be due to autofusion of the spine for prolonged immobilization and distraction with a rigid device. Also, multiple studies have shown significant numbers of implant-related complications. Watanabe study, 50 out of 88 patients had implant-related complications, or 72%. Dislodgement of the proximal foundation, increased upper curve, increased kyphosis, increased number of procedures, issues with bone metal interface. Growing spine study groups have shown that in patients with thoracic kyphosis, there's an increased trend to complications and rod breakage with increased thoracic kyphosis. So our question is by changing the kind of rod we use, can we change the forces across the spine and make a more gradual transition, more of a load sharing while still having stability? So we looked at PEEK rods, which are approved for adult single-stage posterior fusions associated with anterior cage, but not approved for any long posterior usage or usage in pediatric age group. PEEK has been increasingly used as a biomaterial for trauma, orthopedic, and spinal implants. It's a thermoplastic polymer whose chemical structure maintains stability at temperatures exceeding 300 degrees centigrade, resists chemical and radiation damage, exhibits greater strength per mass than many metals, and offers compatibility with many reinforcing agents. So we wanted to determine the biomechanical property differences between uninstrumented control spines, spine instrumented with simulated PEEK growing rod constructs. Again, we went back to our pig model. We looked at 6 of them, uninstrumented spine versus 6.25 PEEK rods versus titanium alloy 4mm rods and cobalt chrome alloy 5mm rods. We tested them again in lateral bending, flexion, extension, 5 Newton-meter moment applied, and we measured the range of motion at each intervertebral joint. And again, this is what we look like. Pedicle screws at the top, pedicle screws at the bottom, and either a titanium rod, 4.5, a 5 cobalt chrome rod, or a 6.25 PEEK rod. Rotations were generated from a custom program, maximum range of motion chosen, and plot for each thoracic level. Two-tailed T-tails were done, lateral bending, flexion, extension, compare total range of motion of uninstrumented region for control and PEEK, and then PEEK versus cobalt chrome. And this is what it looked like. Range of motion, titanium, cobalt chrome, and the PEEK. And again, flexion extension. So range of motion of the PEEK rods was closer to metal rods than to the control. But lateral bending, flexion extension significantly increased over the controls, though considerably less than the control itself. So this is the first early feasibility study of using PEEK constructs. In vitro testing, there were non-scoliotic spines, and the limitation is the fatigue of PEEK. We did not test these to fatigue. First comparison of the theoretically using biomechanical studies for PEEK growing rods. The problem is we were using 6.25 PEEK rods, which is what's commercially available. Obviously, 6.25 screws are really going to be an issue in these little kids. But I think this is something that's worth exploring and may be the answer to autofusion and law of diminishing returns if we have something that's more compatible with normal spinal motion than the stiff constructs we currently use. So again, simulated growing rod constructs with peak rods showed significantly greater flexibility compared with cobalt chrome rods. Peak rods provided significantly increased stability compared with uninstrumented controls, and peak rods may become an option for early onset patients. Thanks.
On patients now, I was actually.
So no, this is still, we're still in the biomechanical testing stage. It is not commercially available. So the problems are I think, are multiple. As I said, we were using 6.25 peak rods, which is what's commercially available. So to use screws that big, I think in really little kids is going to be an issue. The other thing is we don't really have a good way to cut the peak rods and then connect the two peak rods. So that's the problem. And the other problem is there's really nothing available. In the States, the instrument companies are very, very concerned about using things off-label that they promote. So while we can use things off-label, they are very concerned about being seen as promoting off-label usage. People have gone to jail in the States over that. So we did this. We could not get any of the available peak rods from the companies or get any support from the companies for this study. We had to go out and find just off-the-shelf peak rod, which you can find, but those weren't meant for spinal instrumentation to use. So I think that's a big issue. So I think there's a possibility going down the road, but the FDA process in the States is getting more and more onerous, and that's something we're going to have to overcome.
Are there any other questions?
Thank you, Professor Stem. So, shall we invite the next chairpersons, Dr. Raghav Dutt and Professor Stem, to chair the next session, please?